Alright, we talked about cryotherapy, and now we're going to talk about thermotherapy. Remember these guys from the Day Without a Santa Claus? Anyway, I always love those guys, the Heatmeister and the Coldmeister. So we talked about the Coldmeister, we're going to talk about the Heatmeister now. So, outline, we're going to talk about the effects of heat, just like we talked about the effects of cold. Clinical indications for superficial heat. We know that the APTA recommendations are that we don't use heat alone to try to achieve long-term outcomes. That makes sense. Of course, we're going to talk about contraindications and precautions, adverse effects, application techniques. We'll just briefly go over them, and then we're going to go in detail in lab. Documentation, and then we're going to review that chart in choosing between the Coldmeister and the Heatmeister. So the learning objectives I have for you for this lecture are to be able to describe or explain how the use of thermotherapy controls pain, increases range of motion, decreases joint stiffness, decreases spasm, and accelerates healing. A lot of it has to do with circulation and just heating up of superficial tissues. Explain the significance of specific heat and thermal conductivity in the application of thermotherapy. I want you to be able to, of course, state the contraindications and precautions and why these physical agents may be potentially harmful. So why are they contraindicated or precautionary? And I want you to describe the potential adverse effects of thermotherapy. So we talked about the effects of cold, hemodynamic effects, neuromuscular effects, and metabolic effects, and then effects on tissue extensibility we'll talk about with heat. So hemodynamically, whereas cold gives you vasoconstriction, heat gives you vasodilation. The heat changes nerve conduction velocity. It increases it, and it increases the firing rate of nerves. It may facilitate an increased pain threshold, and it actually decreases muscle strength. So we'll talk about that. It increases metabolic rate, and it increases tissue extensibility. So it causes vasodilation. It stimulates the cutaneous thermoreceptors, which cause smooth muscle relaxation. The cutaneous thermoreceptors go to the dorsal root ganglion, and they decrease sympathetic androgenic activation, which causes vasodilation. Increased temperature can also increase inflammation, which increases the vasodilator chemicals, the histamines and the prostaglandins, which also cause vasodilation. So when you already have an inflammatory process going on, heat is probably contraindicated. So we're going to use superficial heat to control pain, to increase range of motion and decrease joint stiffness, and to accelerate healing. This is a low-load, prolonged stretch with heat. So this is something that we might be instructing a patient to do at home. They have a knee extension contracture that we are going to put heat on the back of their knee and put a weight on there. They're lying prone. And that low-load, prolonged stretch with the heat helps increase tissue extensibility. So the contraindications: if you're bleeding, you don't want vasodilation, right? So hemorrhage, thrombophlebitis, impaired sensation because you won't be able to tell if it's too hot, impaired ventilation, same thing. Malignancy, you don't want to speed up the metabolism because the cancer cell already has accelerated metabolism, the cancer cells, and we don't want to make it worse. You do not want to use infrared radiation on your eyes. That's probably common sense, but we're not going to do much infrared radiation anyway, but we'll just talk a little bit about it. Precautions: of course, if you have acute injury and inflammation, heat might not be the best thing because we don't want to increase vasodilation. Pregnancy, again, it may be precautionary. It's, you may use it, you may not. If you have impaired circulation, because you might cause edema with impaired circulation. If you already have edema, heat can make it worse. Cardiac insufficiency, because when you're changing the fluid dynamics, the hemodynamics, you're putting extra pressure on your heart. If someone has metal implants, they might have more of a reaction to heat. It's not an absolute contraindication, but it might not be the best thing for them. Open wounds, same thing. The hemodynamic concerns come into play there. If you have a topical counter irritant going on, like a menthol type thing, or a like Bengay, icy hot, whatever, the heat can make it worse, can make it itchy. And if you have demyelinated nerves, heat can be irritating as well. So it's a precaution. The adverse effects of thermotherapy, burns, that's an adverse effect. If you don't have enough insulation, or if the heat is left on too long, you can have burns. Fainting can be an adverse effect of thermotherapy. Excess bleeding because of that vasodilation, and then skin or eye damage if you're using infrared. So usually in the clinic, for superficial heat, we're going to be using hot packs in the hydroculator. We'll use those in lab. You see the picture on the right. We've got lots of towel layers, and we'll talk in lab about how many towel layers you should have. It's listed in the book as well. You don't want to burn someone, so you want to use a lot of insulation. Towels are good insulation because they're that rough surface that traps air, and air has a lower specific heat, and so it's going to slow down the conduction of heat from the hot pack to the person. Paraffin wax, we're going to have that station set up in the lab that you can use optionally. The OTs in my office that are hand specialists use paraffin a lot before their treatment to help increase range of motion and tissue extensibility. Sometimes they use it for sensory stimulation, and it can be really nice for someone with arthritis. It's not something that we generally do as a primary treatment because, again, it's something that people can do at home. Fluidotherapy, it's this little unit. It has a circulating medium, so it uses circulation, it uses convection to transfer heat. It looks like cracked corn. I'm not sure what it's exactly made out of, but it's inside the machine. The machine heats it up. You put your arms in there, and it circulates around, and that convection transfers heat. So my OTs in my office use that a lot as well. I have used it with people for sensory stimulation, for neuromuscular re-ed. That circulating medium gives just more superficial sensory stimulation to the affected limb. The infrared lamp, it's in the book. It's pretty rarely used. It says this in the book as well. It used to be about the only treatment that was available for psoriasis. Now there are medical treatments available, and so it's rarely used. And chances are you will not come across one of these very often. We'll briefly talk about it. We don't have one in lab, so it's just it's like the history of heating technologies when we talk about the infrared lamp. Because of the things that it was largely used to treat before, because they're better treatments now, it's really sort of gone out of favor. One of the advantages of using, you don't have to have an intervening medium because it heats by radiation. And so if you're trying to heat an area that's irregular, conduction wouldn't work as well because it's hard to touch, hard to get something that touches that whole area. And so the radiation from the infrared lamp would be useful. There are a lot of things that make it difficult to use, and I think that's one of the reasons why it's fallen out of favor. That, and then better treatments available. A contrast bath, you can use water at different temperature to do different treatment. We're going to have a station set up for that in the lab, so you can try it. Again, because it's kind of messy, and it can easily be done at home, it's kind of fallen out of favor in the clinic. So if you do use heat, you're going to document the area treated, what you used to heat it, your parameters. If you're using something like infrared or fluidotherapy where you have a temperature or a power, if it's a hot pack, you're just going to say moist heat pack to that individual area, how they were positioned, and their response to the intervention. And you really do want to watch, if say somebody came in and they said, well, I had a hot pack on last time and it was getting kind of hot, but I was almost done, so I didn't say anything about it. And then when I got home, it was pretty red, and I broke out in a couple blisters. You want to document that in today's current chart in the subjective section. You also want to talk to whoever applied the treatment last time to make sure they knew about that, because we want to prevent that from happening in the future. So the things we can do to prevent that is use more insulation, monitor the patient more closely, and or potentially don't use heating modalities on that person if they're sensitive. So this is the choosing between cryotherapy and thermotherapy chart that we've seen before. Thermotherapy and cryotherapy both can decrease pain. They can both decrease muscle spasm. Thermotherapy increases blood flow, where cryotherapy decreases it. It also increases edema, where cryotherapy decreases it. It increases nerve conduction velocity, cryotherapy decreases it. It increases metabolic rate and collagen extensibility, where cryotherapy decreases. It decreases joint stiffness, opposite of cryo, and it has no effect on spasticity, whereas cryotherapy can decrease spasticity. So thermotherapy has no effect on it. Thermotherapy can cause a temporary decrease in muscle strength, so you don't ever want to do your manual muscle testing after you have applied a heat treatment.